pediatrics. The history is Mr. A is a 62-year-old gentleman, a button shop owner from Jharkhand. He was brought with complaints of rapidly progressive memory decline with behavioral changes since 1 month and rapidly progressive functional decline for 20 days and involuntary jerky movements of the right upper limb for 3 days. So he was independent for all activities of daily living and instrumental activities of daily living till 1 month ago. He was running his shop independently. He was going to the ophthalmologist one particular day and he lost his way back. When going back, he was lost and it took some few more hours for him to go back. The following day, he went to the bank and he started counting the notes multiple times. And after he returned home, he started folding the bed sheet multiple times, opening it, folding it. This was seen abnormal by the relatives. And the next day, he was operated in both the eyes for the immature cortical cataract under local anesthesia. And the day mixing the food, but he wouldn't eat it. He would throw the food around. He would walk sideways and not forward, and if held, and he would turn around in circles. And for the past week, so this was worsening like this. And for the past week, he had this excessive, inappropriate laughter and aggressiveness when he was talked to. He would act out his dreams and talk to himself in the mirror. And for 3 days, he had these episodes of loss of consciousness with abnormal posturing of the right arm and involuntary jerky movements of the right arm. And this was not preceded by any fever, headache, no native medication, and no similar history in the past. And he was not ethanol consumer, no known comorbidities he had. This was on examination, he was comatose when he presented our OPD actually with a GCS of V4, V1, M2 with these movements. As you keep seeing, I'll talk. So his blood, he is vitally stable, no pallor icterus. So CNS wise, his pupils are equal and reactive, but he was comatose and he had this posturing of the right arm with jerky movements and flexor, plantars were flexor, and rest of the system was unremarkable. So the differentials we considered for this rapidly progressive cognitive functional decline were with seizures were autoimmune encephalitis, Hashimoto's thyroiditis, prion disease, some metabolic possibility is also there, Wernicke-Korsakoff, and although less likely, syphilis and B12 also we have to rule out. So I would like to take you through this is the main slide, the crux of my presentation, where we would see if a patient presents with a rapidly progressive neurocognitive decline, what should we think of and how do we proceed? In the tauopathy, extrapyramidal syndrome classification, we have this Alzheimer's disease and dementia with Lewy bodies, which are some things we should look out for, and they will also have this extrapyramidal symptoms, as we all know, the history and presentation. Prion disease is, although very rare, something we should look out for, which I'll be talking about now. And inflammatory CNS diseases, these are things, and this on the right side is the reversible things. So we should always be on the lookout for these entities, including encephalitis of many etiologies, neurovascular diseases like recurrent stroke, vasculitis, metabolic encephalopathy, alcohol, and other diseases and mimics. Always we should make sure that this is not delirium, because we know how delirium presents with the and as opposed to this rapid cognitive decline. I won't go into the details. These are the investigations of the patient. I would say fairly normal. Everything is unremarkable. I won't go into the details. Other investigations to look out for reversible cause of dementia, B12, thyroid antibodies, all were normal. CSF analysis was done. It was glucose was in the normal range, protein was in the normal range, Alzheimer's and encephalitis panel was normal. EEG showed generalized periodic lateralized epileptiform discharges. This was his MRI. So the MRI showed diffusion high signal in the DWI images. I don't know if you can appreciate this cortical ribboning here, and this I increased the uptake, high intensity signals in the cortical putamen. As you can see, this cortical ribboning. So with the given history and this cortical ribboning, we were almost pretty sure that we had the diagnosis of prion disease, which is Creutzfeldt-Jakob disease. I'll talk quickly about this. So there's three different types. Most commonly, we see this sporadic variant, which is 85 to 90%. These are all the subtypes. I won't go into details of them. Acquired is very less known. So Dr. Hans Creutzfeldt and Alphonse Jacob described this entity in 1920 and 21 respectively. Separately, they found it, and the presentation is that patients of present at a median age of 56 years, and they more often than not die within the first year of symptom onset. And the neuropsychiatric symptoms they present with are dementia, behavior abnormalities, higher cortical functional deficits like aphasia, hypraxia, frontal lobe syndromes, and myoclonus is present in 90% of patients, as did our patient. Then cerebellar manifestations, corticospinal tract involvement can be there, and extrapyramidal signs can also be there. I'll quickly go through the radiology. Most important and most useful radiology modality we use is the MRI, especially the diffusion weighted imaging. And if you do serial MRIs, you can see how it progresses as the disease progresses, and contrast is not necessary unless we want to exclude other diseases. Radiological differences could be a stroke, vasculitis, but stroke, as we all know, is we would be able to say otherwise. And serial CT may give some cortical atrophy, but that is not recommended. EEG shows this characteristic periodic sharp wave complexes, which are present in 67 to 95% of patients. And this is particularly not present in other kinds of CGD, like the genetic variant and the acquired variant. CSF usually is unremarkable by itself. There's no cells or glucose would be normal. They have this assay called real-time quaking induced conversion, which is 90% sensitive and 99% specific, but we do not have it here, nor in NIMHANS. 1433 is what we do in NIMHANS. CSF has to be sent within the 48 hours of collection, and we weren't able to send it for this patient, but it's also an adjunct. And sometimes people say they have described elevated tau proteins have been there as well. So this is the Center for Disease Control criteria for probable diagnosis of sporadic Creutzfeldt-Jakob disease. So they should have neuropsychiatric disorder with a positive RT-QAIC test, or what we have is progressive dementia with at least two of the following myoclonus: visual cerebellar dysfunction, pyramidal and extrapyramidal, akinetic mutism, and positive 1433 CSF assay. And routine investigations obviously should not suggest an alternative diagnosis. Very quickly, the pathophysiology of prion disease. Prions are actually normal cellular proteins which are present in the cell membrane, and they are found in both neural and non-neural cells. But they misfold. A conformational isomer of that misfolding is the SC variant. And this is how it happens. There is two lines of thinking as to how this amyloid or the protein homodimer ends up being deposited in the neurons. I won't go into detail. The two big thoughts of schools of thought are the refolding replication model and the seeding replication model, where this energy barrier has to be broken to form the monomer, whereas the other seeding replication model says that both variants are present in the normal patient, and after inhibition is broken down, they will form this cascade of autocatalytic conformational conversion. I won't go into the details. And so this is how we look at the gross pathology of a patient with Creutzfeldt-Jakob disease. You can see how the cerebellum is atrophied here, and the occipital lobe is also atrophied. And on the microscope, you would see astrocytic gliosis with vacuolation, and this is the ultrastructure showing vacuolation and swelling. So interestingly, last two slides, I'll talk about how we found this study, where there's a study actually presented in BMJ, where patients who underwent intraocular procedures, be it a cataract surgery or a dacryorhinocystostomy, had this higher probability of developing a Creutzfeldt-Jakob disease. And they actually looked back at the history of patients who were presented with CJD and found that a significant amount of them had intraocular surgery, and they published as to how common it is after having undergone this surgery. Actually, for our patient though, his symptoms started one day prior to the surgery. So could be a red herring. So finally, I would end with this slide where we are also all of us at risk of developing a CJD if we eat salami or uncooked meat. So especially the gizzard of the chicken is notoriously famous for having this possibility of producing CJD. And thank you.
Thank you for.
Oh, yes, and actually now in retrospect, we asked the patient if he had he. I mean, it was a very rare thing to ask, but did he ever eat anything abnormal? So history is that he would go hunting into the forest and hunt wild game and poultry and have that in his teenage. So that probably had caused this.
Good, you said that because I was wondering.
So beef also he was consuming this.
I was wondering what the topic meant in terms of context. Thank you for the presentation. So, what is the link between off-the-shelf surgery and?
So they're saying unclean instruments, especially in third world countries, being used have I mean, they didn't say how it happens, but they have found that.
I'm getting a little confused from your presentation and pathogenesis. It sounds like a very slowly progressive condition, isn't it? Or is it an acute condition?
It's an acute, rapidly progressive dementia.
Okay.
The differential
No,
would
but
be.
then pathogenically in the body, is it acute?
There should be a trigger to push it from.
No, because if you've got amyloid deposits and all, it doesn't happen overnight, right?
Yes, sir. No, yes, sir. That's so. For that inhibition is broken. So amyloid prion is present in all cells, but for prion to become this atypical prion to cause CJD,
something is missing.
Because the prion one is misfolded. Can we say it's present in all cells?
So the PRPC variant is present in all cells, sir. It becomes the SC variant after a pathological prion.
When it's misfolded.
Yes, sir.
When it's misfolded, it's called a prion.
Something is missing. I don't know how this can happen like one day before he had a surgery and or the surgery and the next day it happened.
For him, it could be a red.
I know the other case series. Anyway, thank you very much. Any questions from the house or online? Thank you, Amos.
Thank you.
Next, we have